Thank you very much, Professor Viter.
Thank you.
And the next presenter is George Andrikopoulos from Greece, Athens. And he has to present the Athens experience.
Good evening, Professor Vardas and Dr. Mavroyianni and Dr. Sviter. I hope you listen to me well. And I hope you also see the slides. Can you please reassure me that you can see them? Okay. So thank you for the invitation to discuss our brief but valuable experience on MRI-guided ablation. This is the hospital where I come from. We want to be proud of our EP lab, but we're mostly known for being supporters of our Greek national basketball team and Giannis Andrikopoulos. And I would like to explain to you why I decided more than 3 years ago, to get involved with this project. The most important reason is because it was there for many reasons, for many years. At the early days of AF ablation, when transeptal was considered more tricky business and was related with more complications, MRI-guided transeptal was already published in animal studies. And when we did that review for the heart with Professor Vardas, we discussed the importance of MRI ablation, and I read everything that existed by that age with great interest. It was very promising. And some years later, we had the opportunity to see that MRI cryoablation was feasible. And I thought that perhaps the future of AF ablation and ventricular tachycardia ablation could have been related to our ability to see the real anatomy. Because anatomy is hugely important, and us electrophysiologists tend to have a misleading option about the human anatomy because we are so confident for the electroanatomical models we create. But these static images are not living anatomy. And we have done our homework with MRI anatomy, and we've been printing for many years the atria of patients undergoing cryoablation, because I was certain these days that cryoablation's efficacy and safety was closely related to the anatomy of the veins. This is the major disadvantage of the method. And I had the luxury to see that uncommon is common, as it was published by another college from Italy a few years ago. Uncommon is common in electrophysiology, and living anatomy has nothing to do with our still electroanatomic models. Like this case where this young female was scheduled for AF ablation, but if she hadn't undergone an MRI before the procedure, we would be rather unsuccessful to isolate all veins and have good clinical results. Even live CT imaging integrated into fluoroscopy, which I have tried extensively in my lab, does not really provide living anatomy because it's a static image standing in front of fluoroscopy. So it looked like ICMR ablation was the only way to have the true aspect of living anatomy during the procedures, which is very important. And is very important, especially in complex cases, like this patient who had undergone an extensive surgery in the right atria. And this patient and other patients like him cannot be ablated because, you know, flutter ablation is very easy, is what we give to our young colleagues because we feel that this is easy and is associated with very few complications nowadays. But in some cases, we used to say that CTI, which is isthmus-dependent flutter, can be more problematic than PVI. And indeed it can be. So although it's a very easy to do ablation, flutter ablation can be very problematic in certain cases. On top of that is the important issue of safety. Regardless of what we do, still regardless if we are trying to reduce fluoroscopy, still there is a significant proportion of health hazards for our patients and for electrophysiologists. You are all aware of the study showing that the life expectancy of electrophysiologists in the US is 5 to 10 years lower. So we have strong feeling that we want to reduce or even to eliminate fluoroscopy from our labs. And trying to be more safe, sometimes we can be more dangerous because of lack of information about anatomy. This is the worst nightmare I had in my lab during the last decade, and it was not in the left atria. It was because of IC, when there was a rupture of a very anomalous iliac vein, and the patient got in serious health risks because we wanted to increase safety and increase our understanding about the anatomy of the atria using IC. So this is, of course, we managed to stent this iliac vein, but still, when you go with conventional means for increased safety, sometimes you get less safety than you want. So finally, we wanted to be on board of a promising technology, a technology that one I thought by that time, and I still believe, may provide us with more tools to achieve ablations in areas that we are not very, very effective today. Lack of efficacy because of limited information of anatomy remains, I think, the cornerstone of the problematic procedures we do in electrophysiology, procedures with low efficacy. And CMR has been already used to increase efficacy in ventricular tachycardia, you all know that. So I was really motivated. I wanted to try how to have a personal experience of how to increase safety and efficacy of our procedures. Finally, I decided to do that because it was feasible. It was the Leipzig, the number of cases performed in Leipzig, and our input for college that and for young fellows of my lab that have been trained there was strong motivation to make us try to have a personal opinion about this procedure. So when we started, a few months before September 2022, when we did our first procedures, we began with this manuscript that was published by Maria Haldoupi from the Netherlands. And we tried to prepare our lab and prepare ourselves for this procedure. And we did the first procedure in our MRI lab. And I have to say that the agony we had by that time, the agony I had, is the restrictions we had inside the lab, because when you start an ICMR program of ablations, the first thing you have to do is to consider that everything will go wrong. And you have to be prepared for all these situations where everything goes wrong. For instance, I have never experienced atrioventricular block during common flutter ablation, but you want to be prepared when you do the first case of ICMR ablation. And keep in mind that at least by that time, we had no pacemaker capable to provide temporary pacemaker inside the room. So we had prepared everything outside of the MRI room. And you have also to be prepared for the case of a life-threatening tamponade during the procedure, or even if you have never seen that situation during 20 years doing flutter ablations. Still, you have to be prepared for everything. And this is a little bit complex because there are certain things you cannot do in MRI lab. But the best thing about preparing for this first case is that for the first time we had to collaborate with the imaging department of our hospital. So for the first time during the preparation of the procedure, I had the opportunity to see different aspects of the anatomy of the heart, because electrophysiologists, we use certain projections, LAO, LL, fixed projections, and we don't have a really 3D visualization of cardiac anatomy in our mind. So I think I really got improved as a conventional electrophysiologist through this ICMR experience. And it was a rather good experience. This is the first case. Okay, it took us 3 hours because we had problems with connections that, although we had tried that before, they did appear during the first case. But we did not have problems with cannulation of coronary sinus. It is amazingly easy in the ICMR environment, like it was mentioned by Dr. Svita. I thought it was going to be difficult, but it is not. We were lucky enough to have very good results in the first cases, and we achieved by the ventricular bidirectional block in all cases, although the second case we did relapse after 3 months, and we had to do it with conventional ablation. Still, I think the whole these first 4 procedures were really smoothly, and the patients had no problem, and we had rather good results. And we had also the opportunity not only to visualize the exact position of our catheter in relation to the pouch, but in relation to the isthmus, but one of the patients had a huge pouch, and I think it would be more difficult to do that in the environment of a conventional RF guided ablation. Of course, today we have PFA, so the whole discussion by those years, it's a different discussion today because new dual energy or PFA catheters may solve the problems of rare cases when a huge pouch prevents block of CTI. But still, the clinical workflow for CMR ablation, for flutter ablation, I think is no problem for the average electrophysiologist. The whole procedure will make electrophysiologists better, and I have to emphasize that. I should encourage the new electrophysiologists to follow training for ICMR ablation, because it's the only way to understand the importance of living anatomy, because when you see your catheter moving with the breathing of the patient, moving differently depending on the heart rhythm, moving differently in extrasystoles, then you understand what is the huge difference between living anatomy and what we see in electroanatomic models. Even when adjusted for breathing, still it has nothing to do with the real living anatomy. So is this procedure a glimpse to the future? I still wonder, because you all know, and I have to show that, apologizing for stopping our ICMR program for ablation in our hospitals. The problem is atrial fibrillation, because I thought that atrial flutter ablation, common CTI flutter ablation, would be a step before using ICMR ablations with PFA, because at the same week we started ICMR ablations, we started PFA ablations in our department. And I thought it would be easy to join these 2 very important projects for electrophysiology in the near future, which is not the case. From the economic point of view, for an ICMR ablation program to be cost-effective in a hospital, it has to be related with atrial fibrillation ablation, because it's almost 70% of what we do, and more than 80% of the income of an EP lab. And it's a still very important thing to realize that electrophysiologists have not been able to achieve perfect PVI isolation yet, regardless of the energy and the modalities we use. And perhaps ICMR ablation will be able, if combined with novel energy sources, to increase these poor results we had so far. So if we say that ICMR guided AF ablation is a glimpse to the future of this technology, then we should emphasize the importance of real-time visualization of ablation lesions. I think this is the holy grail for electrophysiology, to be able to stop in an individualized basis, because every patient needs a different energy protocol, and we have a unified protocol for all our patients, regardless of gender and other characteristics. And we mentioned some of these issues in a review we published a few years ago, and it looks really outdated these days. However, we have very encouraging reports in the literature. This one that is just published in the JAMA Cardiology entertains the issue of ventricular ablation in right ventricle outflow, and it's very important because it's one of the ablations where we have to be better, and MRI, if applicable to this ablation, can be very important. Finishing, I would like to remind to myself mostly, because economic restraints was the main reason for stopping this program, that the value of innovation of MRI ablation, I think, is huge. And although the cost of it for the time being may be not cost effective for the management of our patients, but the value of innovation of atrial fibrillation ablation was huge 20 years ago. The cost of AF ablation was 5 times the cost it is today. And when we published that review with Professor Vardas, it was one of the first in this field. The AF ablation was 5 times more costly than today. You had to spend 3 hours in the lab. But today, we spend less than 1 hour in the lab, and we pay 1/5 of the cost. So ICMR ablation of cardiac arrhythmias is not only a deep dive in the future for arrhythmias management, but I think is an ablation procedure that will be valuable in the near future. Thank you very much for your attention.
Thank you very much, Dr. Andrikopoulos, for your very nice presentation, which was indeed very carefully organized, and you had to express clearly both your optimism but also your concerns. I think this presentation was very balanced. Is any question from the audience? Indeed, but I see here is that there is not any question from the audience at the moment. Professor Sviter? You are mute.
Okay, better now. Yeah, it was a very good, interesting talk. I was specifically also interested in the economical considerations. We did also quite a lot of economic calculations for using MR for diagnostics, for searching coronary artery disease and indication for revascularization. We did a lot of studies for cost effectiveness. Nothing so far we did on electrophysiology. I think the change of a conventional MR laboratory into an interventional MR laboratory is not that expensive. So I think if you would calculate the use of the lab per hour, and you look at the reimbursement of an electrophysiological procedure per hour, I'm not sure that the difference is that large, but it might be different. It's for sure different in different countries, but in principle, you can just take the cost for 1 hour MR lab, which is maybe 600-800 Swiss francs in Switzerland, something like that. Then you add a little bit of investment for the equipment that you have to add, but this is not that expensive, I would say. So this would be then divided up over 5 years or 8 years use. Would be interesting to see such a calculation with current numbers, because you said these AF calculations date back for a few years.
Well, what we did, thank you very much for the question. what we did before starting the problem is calculate the costs. The costs were affordable, especially with the help of Imbric, and the guys of that company were very helpful with us. But when we did the first procedures, we realized that we should use MRI machine for many hours, and MRI is a very important part of the work of the hospital. So we costed much money to the hospital because we occupied the MRI room for many hours. That was a problematic situation. And that's why I really envied my friends in Netherlands that built an MRI inside the IP lab. So I would encourage those who design new hospitals to have an MRI located in EP lab, because if you use the MRI of the hospital, which is used for general purposes, it can never be cost effective.
Yeah.
Okay. Yeah. Okay. Yeah. That's interesting that there is usually a lack of scan time in all hospitals. The MR machines, they are fully booked. And if you go to the radiology chief and you ask for 1 day, 2 days per week, they say, I have no idea, it's not possible. So I think it would be good to go into a business plan with the hospital management and to buy a 1.5 Tesla machine, which is less costly than a 3 Tesla. 1.5 would be better for interventional than other machine types, I would say. So you go to the not most costly machine type. And then if you would use the machine like 50% per week for diagnostics, so this is reimbursed, then you can use the rest of the time 50% for interventions. And then, of course, yeah, you need to have a good workflow in the MR unit that you don't spend too much time. But what we saw, which was very impressive for me, if you do the interventions here, the first time we did several rehearsals here, but still the first patient, we discussed still who is doing what and can you do this, and the other holds this line and this cable. And after 5 patients, we were much faster. I think there is a very steep learning curve, and you can go to much faster utilization of the infrastructure without hurry up, but just you know what you do. So the cost effectiveness would increase during the first year quite a bit.
Yeah, this sounds very reasonable indeed. If there is not anything else to discuss, I hope you agree, Professor Witter, to present yourself as the next